I think it really was the identification of EGFR mutations that were revolutionary. It's like you discovered a totally new kind of cancer, but actually it's just a subset of lung cancer. And so that prompted people to think, well, maybe there's that subset and another subset and another subset. And so the whole way you think about treating lung cancer has changed completely in the last 10 years.
There's been a huge change in how we treat non-small cell lung cancer. Small cell lung cancer, unfortunately, hasn't made a lot of big progress yet. But for non-small cell, instead of taking that group and just saying, okay, here's all the non-small cell, we now can divide people up quite a bit more and be able to personalize the treatment a bit more based on that. And even more recently, this EML4-ALK is another gene that can be changed in some lung cancer, a small number, but when we find those people that have that change, we treat them very differently. For some patients, we know that there has been a change on a molecular level in the cells that became the cancer. So we know to look for the epidermal growth factor receptor mutations, knowing that for some patients, about 10% of all lung cancer patients, for reasons we don't understand, there was a change in that protein and that gene that made that protein. And when that change happened, it changed the whole cell. A gene that's mutated is going to make a protein that's different than it's supposed to be. A gene that's amplified just means there's going to be more of it, because suddenly the cell had the EGFR protein on all the time. It's usually turned on or off, regulated. It's turned on all the time, and when it's turned on all the time, that leads to the cancer.
Occasionally, a genetic event took place in that receptor that was essentially like putting your foot on the accelerator to your car and just pressing it to the floorboard and not having any brakes. In other words, it would force cells to grow at an incredibly rapid pace and not die at the appropriate pace.
Usually what I tell a patient is a mutation is something that's gone wrong in your cancer. For the most part, most of the cells can have this, but it's only in your cancer. It's not something that this mutation, like the EGFR mutation, you can't pass it down to your kids. Okay, and that's always a concern. And so we know that, again, the mutation, if there is a mutation present, it's a primary driver of how the cancer formed and why the cancer is growing.
Most patients who have these driver mutations, when we know that they have it and give them the right drug, they have a very good response. But it isn't a cure yet, because eventually the tumor cells figure out a way around the treatments that we have, and it's this game of, cancer cells figure out how to get resistant. We're trying to figure out how to overcome that resistance. But we don't know how to do that for everybody yet.
After probably about 9 to 16 months or so, on average, the tumors will start to grow again. And from studies where we've rebiopsied patients, we take tissue from the growing lesions, we've shown that they have another mutation in there which blocks binding of the drug. And based on that, we're now trying to design trials and find the most effective therapy to kill that second mutation. Similarly, another fraction of patients will have activation of another signaling protein. So based on that, we design new trials with other drugs that try to kill that other signaling protein. So we're trying to stay ahead of the curve and figure out, how these tumors are sensitive, but then how they become resistant, and then can we get a better therapy for patients.
This is how much we know right now, and this is how much we have left to learn. So I think certainly compared to 5 years ago, certainly the field is rapidly changing in our minds, but certainly to patients it may not be rapidly enough. But I think that over time things are going to change.
And the latest and the greatest doesn't mean it's the best, right? I mean, because if the latest and the greatest was the best, we wouldn't be sitting here talking about all the people that we haven't been able to help. Having said that, the latest and the greatest, if studied properly, may be the best, Gamma knife, for example. So if I saw a patient with brain metastases today with lung cancer or kidney cancer, or other kinds of cancers, we would have a conversation about Gamma knife before we'd even think about whole brain radiation. The nature of what we've been able to accomplish for patients has just been dramatic, but it's not right for everybody. But it's taken us a decade to prove that.